So, good evening, all the aspirants present here. Today, we have the topic is acute coronary care, and the speaker that we have here is Dr. Sangshaptak Saha, who is the Associate Consultant Critical Care Medicine at Apollo Hospital, Kolkata.
Hello everybody, I'm Sangshaptak. So today's topic for discussion is acute coronary care. Firstly, we shall have brief theoretical aspects of the acute coronary syndrome, mostly both STEMI and non-STEMI, and in the end we have a few ECGs just for the more practical aspects. It will be something like 40-45 minute session at max. Okay, so let's start. So when I was doing my DM at AIIMS Delhi, acute coronary care has always been, one of the common topics not only asked in the grand rounds but also in the entrance exams, as well as it was asked in my DM exit exams as well. Because not only in the cardiothoracic ICU, but this acute coronary syndrome can occur in any patient in an ICU, the sepsis patients, the AKI patients, then the simple patients with pneumonia, with ARDS, just because of the oxygen uh, at delivery and need mismatch, it can occur. So let's start. So in 2018, the fourth universal definition was given, and we have come a long way from 1950 to 2018. Where there is definition, what they state is mostly it stated that there is a clinical part and there is a pathological aspect. So the clinical aspect stated that so there is a clinical aspect and a pathological aspect. The clinical aspect stated that obviously stated that there should be a presence of acute myocardial injury, for which we shall understand by abnormal cardiac biomarkers. And the pathological definition is that there will be myocardial cell death as a result of prolonged ischemia. And this rise in abnormal cardiac biomarkers, that is defined as an elevated cardiac troponin value above 99% of upper range of normal limits. So the myocardial injury related to acute myocardial ischemia can occur because of the atherosclerotic plug disruption. It can occur as a stelling because of myocardial injury because of the oxygen supply demand imbalance. It can occur because of reduced myocardial perfusion or increased myocardial oxygen demand. So if there is increased myocardial oxygen demand, that can occur because of the tachyarrhythmias or simple tachycardias or severe hypertension. So a patient who has got a heart rate of more than 140 or 150 beats per minute, which is common in any case of sepsis or trauma patients. So in all of them, there is a more chance of this oxygen supply demand imbalance. Other than that, if there is reduced myocardial perfusion because of the opposite, that is bradyarrhythmias, because of persistent hypotension or shock, once again it can occur in a general ICU. This hypotension or shock, respiratory failures, severe anemia, yes, hemoglobin less than 5 grams per percent, which is mostly in a case of hemorrhagic shock or in trauma patients or a post-op patients, mostly in those intra-op or post-op patients. And these are the cases which we mostly see in a cardiac ICU. That is vasospasms, embolisms, coronary artery dissections. Apart from these three cases, all of them can occur in a general ICU also. And of course, this can occur in any patient with the risk factors like diabetes hypertension, obesity, then elderly patients, uric acid high, age, right? Then smokers, that all the risk factors that we know of. Smokers, then alcohol consumption beyond the normal limits, all of these things. So basic point is that etiology can be varied. It should be suspected in any patient who has got a shock, in whom we are seeing there is a rise in lactate, who is having a cold perfusion, cold peripheries, and of course echo is machine is available, the bedside focus machine, that is the echo machine, and all the people who are working in an ICU, right from the RMOs to the the consultants or the associate consultants or whoever is working, they should be at the bedside. They should be able to do a basic echo to rule out the RWMA, regional wall motion abnormality, and to look at the and to get at least a basic estimate of the ejection fraction. Okay. So moving on, other causes, we all know that there can be separate other causes. The cardiac conditions we won't discuss. The systemic conditions like sepsis, infections, CKD, subarachnoid hemorrhage, pulmonary embolisms, then the chemotherapeutic agents, especially the doxorubicin, daunorubicin, in general critically ill patients, and these amyloidosis, sarcoidosis, I think are not that common. Sarcoidosis is a bit common, especially if you're working in a pulmonary ICU like I am. But amyloidosis, yes, it's a bit rare. So, lot of systemic conditions can cause this oxygen supply demand mismatch. And among the cardiac conditions, you all know it can be heart failure, myocarditis, then coronary revascularization, that is post-procedure, as well as defibrillator shocks. So classification of MI, it is dependent upon how the MI is occurring. Type 1 is mostly because of the myocardial infarction where there is a atherosclerotic plaque rupture or damage. In type 2, there is oxygen demand and supply mismatch. In type 3, it is associated with sudden cardiac death. Type 4 is associated with the type 4 and type 5 are associated with the procedures. Type 4 is associated with PCI and type 5 is associated with CAPG. So type 1 AMI, how to diagnose it? So diagnosis is pretty straightforward. There will be the symptoms, that is the chest pain, new onset ischemic ECG changes. Over hours, after 4 hours, if you repeat, there will be the pathological Q waves which can be absent if you are doing an ECG early enough, or if the patient has presented early enough. And the echo evidence of new loss of viable myocardium, that is a new regional wall motion abnormality, which was telling, it's the bedside echocardiography will diagnose it. And finally, this is the cardiologist domain, identification of coronary thrombus by angiography, right? So one is, so these are the important things. So this is the clinical history, right? Signs, symptoms of a crushing chest pain, a very severe chest pain, which is a central in location, which is not identifiable by single finger. So pinpoint location not be possible. If it is possible, then the chance of being a cardiac chest pain decreases. Then the pain relating to the jaws, to the inner surface of the arms, towards the interscapular space. Although the specificity is very less, but if the patient in an appropriate clinical condition is demonstrating these signs or telling these symptoms specifically, be alert, it can be a AMI feature. Then of course you are doing the ECG. There are two things. These will be the fresh ECG will also show these ischemic changes, that is the ST depression, ST elevation, QOF changes, and QOF changes will be in the second ECG. But if the patient has delayed, if the patient has appeared at 4 hours, 5 hours, then the QOS can be in the first ECG also. This is the echo, which can be done at the bedside. And finally, this is the cath lab finding. So this was about type 1 AMI. Type 2 AMI is almost same. Symptoms are same. Ischemic history changes are same. Pathological QFs is also same. Echo findings are the same. The only thing is that because here it is an oxygen supply demand mismatch, so this feature, the coronary thrombus by angiography will not be present. Okay, so type 2 AMI is there. By definition, the acute plug disruption will not be a feature of type 2 AMI, and this is the most common AMI in a general ICU. And then we move to the type 3 AMI and type 4 AMI. These we shall discuss later on also, so I'm not discussing it here. Type 3 AMI, patients who did not give us a chance to investigate and have died. So basically an autopsy finding, right? Type 4, which is the related to the PCI. So if the PCI, the cardiac troponin changes will be more than 99% of the upper limit of the normal, or more than 20% of the baseline value. So type 4 AMI, there will be the fresh changes, fresh QF changes, imaging evidence, echocardiography, and angiographic findings. The only thing absent are the clinical features because it is a post-procedure. So the clinical feature, that is the typical chest pain, will not be there. So the clinical feature classically absent. Why? Because it is post-procedure and it should occur within 48 hours of the procedure. And the cutoff is 5 times. So the cardiac troponin should be more than 5 times and it should occur within 48 hours of the procedure. I hope my screen is visible, right? Type 4B. Type 4B. So 4A is these things and 4B, the cardiologist has already placed a stent or a scaffold and a thrombosis has occurred there. That is a restenosis has occurred. And type 5 is almost same thing. It is just post CABG and there it is 5 times, here it is more than 10 times and it is same less than 48 hours and the clinical criteria are the same. So these are the 5 types of AMI very frequently asked in EDIC part 1. They will simply, the EDIC part 1 is not that clinical. They will simply ask you that this has happened, what is the type of AMI the patient has suffered from. By type, they mean this type 1 or type 4 or type 5. So if you just know the basic definition, you'll be able to answer. They will not ask you in details. It's an MCQ based exam. Epidemiology of AMI, I think I have already discussed about the risk factors: smoking, blood lipid levels, hypertension, diabetes, morbid obesity, less physical activity, excess alcohol consumption, and the diet. So these we have already discussed. This is the Indian classification in EDIC. You will not need this obviously, as I am not discussing. Clinical features of acute coronary syndrome. I have already discussed the typical chest pain. I have already discussed. So other than the chest pain, what will be the findings? So this is obviously the number one finding, right? The other findings are diaphoresis. In the EDIC exam also, they give a lot of importance to diaphoresis. Why? Because studies have shown that this is associated with worse prognosis. And then unfortunately the patients can also present with sudden cardiac death, right? So sudden cardiac death, that is very unfortunate, but that occurs. Sudden collapse or death can also be the presenting feature. But do remember this diaphoresis thing. They have asked about this diaphoresis in the exam, that the patient has got a diaphoresis and the young patient with diaphoresis, something like this. What is the most likely cause? Obviously, they have not mentioned about the ischemic chest pain. So next we come to features favoring non-cardiac chest pain. So how to rule out a cardiac? We have already discussed the features of cardiac chest pain. So the primary or sole location in mid or lower abdominal region. And as I told, any discomfort which is localized with one finger. So central location, but one finger. It is the patient is able to pinpoint the location. Very unlikely to be a cardiac chest pain, right? Because in ACE, that acute coronary event, what happens is that a part of the myocardium is lost. So it cannot be a single point. It is usually over a more area that it is lost. If it is a constant pain, it is obviously not ACS. Fleeting pain, obviously not ACS. And the pain radiating to the lower extremities will not be ACS. Yes, penetrating to the jaws towards the towards the inner part of the radial part of the this what to call it the upper extremity. These specificities are very much less, but definitely a pain towards the lower extremity will not be the pain of this thing. And do rule out the pleuritic pain in whoever is taking the class on the pneumonia. This pleuritic chest pain is very commonly asked in EDIC 1. Once again, they will just tell you that the patient has this type of pain and they will ask you what is the most likely cause, and the answer will be pleuritic chest pain, a very favorite of the European people. I have given the MRCP also. So in MRCP also they ask about the periodic chest pain, and in EDIC also they ask about this. Not only this, but the heart zoster pain, then musculoskeletal pain. There will be an injury. So read the stem very carefully. The stem is often very long, so try to write the last part of the stem first, what they are asking, and then go start reading the stem from the top and go on excluding the differentials. That will, and definitely do practice it every day at least 1 hour. I know everybody is busy, most of you are working as in a higher post, so time will be less, but do try to practice this for at least 1 hour every day, if possible 2 hours, because otherwise time is an issue in EDIC 1 because the stems are so long. Anyway, so what are the causes of acute chest pain? These are not required. These are the cardiac pains and what I have to rule out. The in EDIC 1, what they will ask is that is ischemia infarct, aortic dissection, pericarditis, pulmonary embolism, and gastrointestinal. So these are the ones that they usually ask. The others are, not usually asked in EDIC part 1. These are the mimickers, and that is why they ask those things. Pericarditis, pulmonary pericarditis, usually that the patient will, they will have a history of effusion, or they'll give an ECG where there will be the concave shaped ST changes in all the leads, or there will be that the NSAIDs usually relieve the pain. So one of these 3-4 points will be there. So look out for it. Pulmonary embolism obviously is a separate topic, it's a separate issue. They will give a typical history of pulmonary embolism, a flight history, surgical history, immobilization history, and from there you'll get the idea. So coming to the diagnosis of acute coronary syndrome, the most important question is this, that what is the maximum amount of time that is allowed before you can do an ECG. So there they have got this ambulance, this hospital service is very rapid. They will take the ambulance, go to your place, and bring you from there to here. Obviously, that is also present in India also, but or in any other country. But there it is very much recommended that if the patient is complaining of a chest pain and is suspecting ACS, that is the EMS people who will be in ambulance, they will have to do an ECG as soon as possible, and the maximum time allowed is 10 minutes. It once again is a question which has been asked previously in EDIC 1, a direct question. What is the maximum amount of time that can pass before you do an ECG? So the answer is 10 minutes. If you know, you know. If you do not know, you will have to, leave the question. There is no other way. And these we shall discuss later on also. That the posterior, if you want to assess the posterior chest wall, you have to put in the V7, V8, V9. If you suspect a posterior AMI. If you suspect a right ventricular infarct, you have to put in V3R and V4R also. But these are practically not done, right? So posterior AMI usually will also have a features of inferolateral AMI. So the changes will also be there in lead 2, lead 3, as well as in the 1 AVL. And in the RV infarct, yes, if you put in V3 or V4R, there will be the ST segment elevations, but the ST depression also present in V1, V2 also. So from there you can get an idea. We shall discuss it in the ECG parts. Okay. So ECG criteria, this is just theoretical. New ST elevation at the J point in 2 contiguous leads with a cut point of more than 1 millimeter. This is for all leads. The only exceptions are V2, V3. So V2, V3, they have got an age and sex specific. So men more than 40 years, it needs to be more than 2 mm. In men under 40 years, it has to be more than 2.5 mm. And in all women, regardless of age, it is more than 1.5 mm. So list is For all women, 1.5 mm. Then for men, the cutoff is 40 years. So more than 40 years, a smaller elevation is enough. So more than equal to 2 mm if the age is more than 40 years. Otherwise, you need a 2.5 mm if the age is less than 40 years. So less than 40 years, chance of AMI is less. So the cutoff is also more. So the changes needs to be more. So this is for ST elevation. Remember, the ST depression has got a different criteria along with the TOF changes. ST depression more than 0.5 mm and TE inversion more than 1 mm in two contiguous leads. So this is the definition of AMI where there is no LBBB and no bundle branch block. Yes. Okay, so there was some ECG criteria. I have, you know, added all the ECGs of the different things and the Wellens and the Winters ECG T waves at the end, so you can see it there also. Patterns, I think we all know this is the ST convex shaped, this is the T inversion right here, right? This is the convex shaped, and this is another form where there is the there is a blending into one dome. You can't differentiate between the ST and the T waves. And these are the different J points. Here it is notched, here it is slurred, here it is well demarcated. The J point is just at the junction of the ST and the T waves. So if there doesn't changes, if it is very prominent, then you can be sure that there is a chance there is early report going on and there is maybe a early ECG change of STEMI. Moving on. Okay, so what does this ECG show? Can somebody just tell me? If I think you can open your mic. So it's a very straightforward ECG. And anyway, this ECG is there in the end also, so you can discuss it there. Anybody?
Yeah, there is ST elevation in V1, V2, V3, and also V4.
Yeah. So which area is involved, or which vessel is involved?
Is left anterior descending branch of the left coronary.
Yeah, it's mostly an anteroseptal, right? Yeah. And there are the changes in lead 2 and lead 2, some T wave changes are also there. But yeah, it's an anteroseptal and the LAD is occluded here. This is another one. If somebody can volunteer.
Okay, I can see leads
inferior
2,
legs.
3, and AVF shows ST elevation.
So yeah, so it's an inferior volume, right?
Yeah.
Okay. These are the atypical electrocardiographic presentations, and this if there is a bundle branch block, then you can't diagnose ECG this STEMI on the basis of the previous criteria. There needs to be an ST segment elevation more than 1 mm in leads with a positive QRS complex. Discordant ST segment elevation more than 5 mm leads to negative ST QRS complex, and concordant ST segment depression more than 1 mm leads V1 to V3. This will not be asked in your EDIC exam, so I think you can skip this part. The exams, the EDIC 1 exam, they have already asked about this hyperacute T waves, De Winters T waves, and these Garbosa-Smith criteria, and the Wellens waves. Okay, and this out of hospital cardiac arrest we won't discuss today, but this out of hospital cardiac arrest and post CPR care, and whether to go for this temperature control and whether to go for this ECMOs and the LVADs. Those things are asked, just the basics, that which trial shows the benefits in the temperature control, how to, so those things are asked. So do go through that when you read those parts. Otherwise, the others we shall discuss today at the end. All the 4 ECGs I have accumulated together, the hyperacute 2SD Winters and Wellens. So here we shall discuss valence type A, type B. Type A, that the biphasic T waves, and type B, deep symmetrical T waves. Type B is by far the more common. Here they mentioned type 75%, but valence, if you diagnose, is almost always these deep symmetrical T waves in the V1, V2, V3, V4, V5, V6. And what are the biphasic T waves? Suppose this is the PQRST, so this was the T wave, but there is an inversion. So this is biphasic T waves. We have gotten, I'm a very bad diagram maker, sorry for that. But yeah, so here this is a type A valence, right? So here just the T wave was going for an upward positive T wave, then it went down. Same thing here, upward, and then it went down. Very typical findings. Just and these are obviously in the V2, V3 only. And here, as you can see, the symmetrical and very prominent inverted T waves again in V2, V3. So valence, we have to look for V2, V3. Don't neglect this. They have asked this with this ECG that what exactly is going on. And valence, you have to tell. This is an MCQ, so we'll see the word valence, and obviously we'll then go and check the ECG. So valence there or not, and it's very easy to get it in the exam. But do know which is type A and type B, because the exams are getting harder. When I gave the exam around 5 years back, top part one, they only asked about valence. At least they were asking about valence. Now they may ask for type B also. Yeah, this is again about the concordance and discordance. Garbosa-Smith criteria, do read about it. This is the criteria which I told here. This is the Garbosa-Smith criteria, basically, is Bundleman block criteria. This concordant and discordant, if it is positive 1 mm, if it is negative 5 mm, and if it is ST segment depression, then it is 1 mm, but only is V1, V2, V3. Just remember this, and I think that is enough for the exam. Okay, so Garbosa-Smith criteria. And yes, Winters T waves. What are Winters T waves? Winters T waves has got two parts. The first part is an ST segment depression. The second part is a peaked T waves, or a subset of hyperacute T waves. Hyperacute T waves. I don't know whether you will get time or not, but there is a site, I think everybody knows, Life in the First Lane. Life in the First Lane, like FTL. There they have got an ECG thing. Just Google it. There they have got these deventers and the valence and all the different types of anterior, anterolateral, high lateral, anteroseptal, inferior, posterior, and these are about the AMI and different types of ECGs. Just go through 10-15 ECGs a day till your exam comes. You will be brilliant in the ECG. It will take 5 seconds to discover, because in the exam very simple ECGs usually comes, but you get nervous and everything. At least I get very nervous even though I see ECG in every patient. So what does deventer theory signify? Signifies proximal LAD occlusion, and this needs to be in V1, V2, V3, V4. And there are two parts. Both parts needs to be present to classify deventers TOS, AC depression and TOF changes, peaked or hyperacute TOFs. So the examples are there. We shall see the examples at the end. These are, as you can see, this is the AC segment depression here, and obviously the hyperacute TOFs here. And this diagram, I think everybody knows. The lateral leads, inferiorly anteroseptal leads. As the doctor told a few ECGs back, anteroseptal leads V1, V4, LAD is blocked. Inferior leads, you all know, 2-3 AVF, usually RCA. If RCA is not in the options, go for the left circumflex. Left circumflex is also a cause, but RCA, if it is an option, go for RCA only. Lateral leads 1 AVL, V5, V6, then that is a typical cause for left circumflex or diagonal of LAD. Left circumflex, RCA, and LAD, everybody knows. And these are the ECG changes which can occur: 2-3 AVF for RCA and 1 AVL, and V1, V2, V3, V4. These are for the LAD. Okay. So here we have got a few ECGs. If somebody can just volunteer and tell there are 2-3 ECGs, just to make it the class a bit more interactive. Otherwise, it's very boring to teach SES because everything is very much theoretical. or we can just go back at the end, when we shall discuss the ECGs here. So we shall continue. Cardiac biomarkers, HS troponin is the latest, and they will ask about the HS troponin. Why? Because they will ask about these things they do not usually ask in an EDIC exam, but the cardiac troponin and the HS troponin they will ask. The others, the CKMB and the myoglobin, those things I don't think they will ask in the exam. So what about a cardiac troponin? Tissue source is mostly heart, and time to increase is 3 to 4 hours, remains elevated for 7 to 10 days. Okay, and CKMB, the main point to remember is it returns to normally 40 to 72 hours, so it is used to diagnose reinfarct. This is the only, if you go to the old EDIC questions, the 7-8 years back, then you will see this question is very common in those times. CKMB role, because it comes back to normally 40 to 72 hours. So reinfarct after the 3 days, if it occurs, we can usually diagnose. But because the cardiac troponin remains in increase for 7 to 10 days, so it is very difficult to it's not possible to diagnose on the basis of cardiac troponin. So what is the difference between troponin T and troponin I? Troponin I, remember, it is high sensitivity and specificity. I means self, that is the highest sensitivity, because in the exam you will get confused which is more sensitive specific. And fast detected, and these things are not very important. Disappear, as I told, by 7 to 10 days. Yes, and what about HS troponin? HS troponin has got a negative predictive value of 99%. So if it is less than the normal range or within the normal range, then the negative predictive value is very high. Otherwise, if it is a very large AMI, if it is in the 10,000s or thousands, then the positive predictive value is very high. But in the middle part, there can be all these causes which can cause a rise in HS troponin. So HS troponin is mostly for the negative predictive value, and if it is very high, then for the positive predictive value. Mostly for negative predictive value, if very high, then positive predictive value is there. Otherwise, mostly for negative predictive value. For exam purpose, negative predictive value to rule out. As I told, the negative predictive value is very high if it is raised repeated 3 hours, and if it is still not in very high, the negative predictive value is close to 100%. It has got a lower cutoff, that is why it is a high sensitivity of 3 to 5 nanogram per liter, and normal tropi is around 14. So facilitates mostly early exclusion. So what I would come into the management. Nearly half of the today's class will be about the management. So firstly, we have taken the history and those things that we shall not discuss. Clinical examination is often unremarkable. If there is hemodynamic instability, that can be there, but many times patient is only complaining of a chest pain and is hemodynamically stable. Unless there is a rupture, there will not be any murmurs. But if there is a mitral regurgitation, if there is a ventricular rupture, septal rupture, papillary muscle rupture, then there is systolic murmur. But obviously, the patient will be grossly hemodynamically unstable, and then you have to immediately go for more invasive procedures like intubations and cardiothoracic OT, or immediate shifting to the cath lab and interventions. And ventricular septal rupture is almost more than 90% mortality is there. So mostly the clinical examination other than the chest pain will be unremarkable. So next you have to go for the biomarkers, troponin, HS troponin, and when to CKMB already discussed, so those will be there. On the basis of this and the ECG, you have to diagnose either it is STEMI or it is a non-STEMI. Previously, there was something called unstable angina. We have unstable angina is when there is a presentation is similar to ACS, but the troponin is not elevated, and ECG changes will be there, ST depression will be there. If none of them are present, then obviously non-cardiac chest pain is there. So for early diagnosis and early rule out, at least a 3-hour algorithm has been put out. In the 3-hour algorithm, what they are mostly telling is that first you have taken a clinical history, then you have done an ECG, and then you have done a HS tropi. The HS tropi is more than the upper limit of the normal. Suppose it is a very high, as I told, it is highly abnormal, then directly go for the invasive management. So suppose it is in the thousands, then no need to wait for anything else, right? And it is obvious an ACS. But if it is raised, the cutoff was around 4 to 6. So if it is something like 100, then repeat it at 3 hours. That is why the name of the algorithm is 3-hour algorithm, because you have to repeat it as 3 hours. And if the troponin there is no change, then we have to look for other differentials. And if now the change has occurred, that is, suppose at 0 hour it was something like 100, and at 3 hour it has gone to like something 250, then go for invasive management. If there is no other, the patient doesn't have a CKD, there is no cardiac injury or no trauma or no other obvious explanation, go for invasive management. So this was when the tropi was raised more than the upper limit of normal. If the initial tropi is less than the upper limit of normal, and if the pain is more than 6 hours, then there is a more chance of differential other causes. So look for the differential diagnosis. And if the pain is more acute, then again repeat the tropi at 3 hours. If no change, look for other diagnosis. If change, go for invasive management. So this, on the basis of this, multiple MCQs can be framed. Do try to read through the MCQs and try to find out different situations and how you approach, because this, on the basis of this algorithm, there can be an MCQ in your exam. Sorry. Once in the ICU, echo, as I was telling for the first minute, echo is indispensable, and you need to do the echo to rule out RWMA, to find out the ejection fraction, to rule out MR, to rule out ventricular septal rupture, to rule out papillary muscle injury, to rule out pericardial effusion and other causes of pulmonary embolisms also. So that is very important. These are the different findings that you can get: normal RWMA, that is perfusion abnormality, diastolic dysfunction, then infarct, scars, those type of things. These are the different views. This is beyond today's topic, because echo, I think, will be another lecture. But mostly you have to look at the 4-chamber, 2-chamber views, as well as the long axis and the short axis views, to get an idea about the regional motion abnormalities and the pericardial effusion and the MR and the TR and diastolic dysfunction and the TAPC, those type of things. TAPC is for right ventricle systole, tricuspid annular plane systolic excursion, which is for the right ventricle systolic function. So initial management, as always, the ABC, history examination, ECG and cardiac monitoring, and the biomarkers you have done. So what next? Next is oxygen. When do you need to give oxygen? We need to give oxygen if the saturation is less than 90%, or if the PaO2 is more than 60, less than 60. So these are the cutoffs. Aspirin is must. Aspirin, obviously you have to give the loading dose. Nitrate, yes. Once we have ruled out, RV infarct and the BP is okay, then you can give nitrates. Morphine or fentanyl is very good if morphine are available. If available, always morphine. If patient is hemodynamically stable, use beta blockers as well. And statins. Statins is 80 milligram loading followed by 80 milligram loading followed by 40 milligram OD. Aspirin is 325 milligram loading followed by 75 milligram OD. And nitrates is also there. If there is persistent pain, what to do in the ICU and what is there in the guideline is an IV calcium channel blocker, nicardipine. That can also be used. It is very good. It works very well. Because if the aspirin is not work, the aspirin, nitrate, and morphine you have given, the patient is still complaining of pain, you can use this. Okay. And just a minute. Yeah. So next is, till a few years back, the second antiplatelet, because you have to go for a DAP, right? A dual antiplatelet therapy. Aspirin we have discussed. The second agent is usually a clopidogrel. But now the guidelines have changed. Not now, in 2019 the guidelines have changed. And it is prasugrel or ticagrelor. If not available, then you can use clopidogrel. The ticagrelor or prasugrel, those are there. The TIMI trials and Timothy trials, which have told that you have to give it at the start. Ticagrelor is 180 milligram loading followed by 90 milligram PD, and it should maintain over 12 months unless there is excessive risk of bleeding. From here onwards, every point is an MCQ, right? So what is your drug of choice? Either ticagrelor or prasugrel. If not in the option, clopidogrel. What is the duration? 12 months. If there is excess of bleeding, then you can consider decrease. The dose is 180 milligram loading followed by 90 BD. Tika dose. What about the GP2B3A inhibitors? GP2B3A inhibitors are only available, only to be used if there is evidence of no reflow or thrombotic complications. So it is not routine. Cangrelor is an IV agent which can be used if they have not received the oral agents. So here, once again, very important for the MCQs, please pay close attention. So a patient has presented with a chest pain and the EMS has been informed. From this point, within the next 10 minutes, the patient should be done with an ECG, as we have discussed previously. The next thing is that what should be the first medical contact point? If it is a PCI center, this is the ECG time, 10 minutes. Primary PCI strategy needs to be undergone and thus less than 60 minutes of wire crossing. So 60 minutes is an MCQ. If the patient first goes to a primary PCI center, if the patient goes to a non-PCI center, then we have to find out whether the time to the next PCI is under 120 minutes or more than 120 minutes. If under 120 minutes, shift the patient to primary PCI and then the time increases to 90 minutes. So if it was a primary PCI capable center, the time was 60 minutes. And if you are shifting to a first to a non-PCI center, then to a PCI center, because the time to shift to less than 120 minutes, then the time becomes 90 minutes. And suppose we have shifted to a non-PCI center and time to PCI is less than more than 120 minutes. Then we have to go for the IV fibrinolytic strategy, right? And then, because here basically you have to give the IV drug, either in a time to IV infusion is less than 10 minutes. All of these time periods are an MCQ. Okay. So yeah, PCI center, non-PCI center, PCI center within 60 minutes, non-PCI center. If shifted to PCI center with 120 minutes, less than 90 minutes. If shifted to PCI center, not possible 120 minutes, fibrinolysis within 10 minutes. This is the easier way to remember. This is the same thing, just in a different format they have told. The only thing extra is that once you have shifted, so suppose the patient was in a non-PCI center, and the time to a PCI center more than 120 minutes. So you have given the IV altiplase, that is a fibrinolytic agent, within 10 minutes. And now you have to shift the patient to PCI center, right? So if the reperfusion is successful, so what is the criteria for reperfusion? ACTUF changes has gone down by 50%. The patient's chest pain is resolving or has resolved, and the patient is hemodynamically stabilizing, and the arrhythmias, if it is occurring firstly, is no longer occurring. So if all of these are happening, that means the patient has responded to fibrinolysis. So then we can go for a routine PCI strategy within 2 hours to 24 hours. This one. But if the reperfusion criteria is not met, then we have to shift the patient to the PCI center and you have to go for an emergency PCI, and this is as soon as possible, preferably within 2 hours, at least less than 2 hours. So once again, everything is an MCQ. I hope this part is clear, because the MCQ will come from this part only, which we are discussing right now. When to give oxygen, when to use aspirin, when to use ticagrelor, which is the agent of choice right now, how long to continue, what is these durations, all of these are MCQs. Okay, so now we have gone for a PCI. So we have to give an axis first. The axis is usually a radial line. The other option is a femoral, but usually you go for a radial line. You do a coronary angiogram, do the interventions, and a peri-procedural pharmacotherapy. What is it? Continue with the dual antiplatelet therapy, continue with the unfractionated heparin or Clexane, and if there is a complication, that is there is a less flow TME grade 1 or grade 2 are achieving, then go for a GP2B3A inhibitors. So this is optional. This is the peri-procedural pharmacotherapy. Important thing is that there is no absolute contraindications. All of these are relative contraindications. Most important ones are active infections, renal dysfunctions, contrast allergy. Access of PCI I have already told. In the radial, there is a lower risk of bleeding, vascular complications are less, and some mortality benefit in some trials, but yeah, in a exam it will not be asked because these are not that good trials. Exam it will not be asked. But yes, radially definitely the preferred line. It is the first choice. These are not required. So just keep these things. Images is just for knowledge purpose. Here obviously there is a stenosis. Once again, these are the very narrow parts. You see, there is narrow part. See, there is no flow here. Once again, these white parts, no flow. This part, no flow. So here it is around 50% block. Here it is around 20% block, right? And you see this is white part is atherosclerotic plaque which is causing this. Very important. Complications are pretty simple, straightforward. A local complications with the bleeding infections, pseudoaneurysms, dissections. A chance of stroke is always there, and on-table death is around 1% mortality is there. Drug-eluting stent is superior to bare metal stent. Nobody is using a bare metal stent now. With a drug-eluting stent almost always. Routine thrombus aspiration not recommended. Both of them are previous exam questions. Okay. Routine thrombus is not recommended. DES is recommended. Steps obviously not required. Yes, peri-procedural I have already told. DAPT, that is dual antiplatelet therapy, is definitely recommended. If you should continue it, a parental anticoagulant, that is the Clexane or the UFH, needs to be there. Aspirin always, ticagrelor is superior to clopidogrel. GP2B3 is a bailout therapy when there is a slow or no reflow, other thrombotic complications. This should be on the fingertips. There is no confusion regarding this type of things. Yeah. So if you're using a low molecular heparin, Clexane, usually you're using a subcut dose, right? Anybody who has worked in ICQ will know. It is a subcut Clexane, low molecular heparin. But in an ACS, the loading is a IV Clexane. Very important to remember. It is a IV bolus of Clexane at a 0.5 milligram per kg. After that, you can go for a subcut BD dose. And if there is a chance for heparin-induced thrombocytopenia, suppose they have mentioned in the question the platelet is low or something like that, then the drug of choice is bivalirudin. Do not use fondaparinux in ACS. There is no role of fondaparinux in ACS. No role. It will never be an answer if the question is on ACS. It is either a low molecular heparin IV bolus. If there is a heat, it is bivalirudin. If there is a kidney problem, it will be unfractionated heparin. 70 to 100 units per kg. I also remember it as 80 units per kg bolus followed by 18 units per kg per hour maintenance. The unfractionated heparin thing. TIMI flow grade, very important. Once again, they will ask about what is TIMI 2. TIMI 2 is partial reperfusion. TIMI 3 is normal. Remember, 3 is normal, 0 is no perfusion, and 1 is partial. Sorry. 2 is partial, 1 is penetration without the perfusion. So this is also the PCI. What about the fibrinolysis? So mostly the dose of various agents will be asked. Altiplase is a drug of choice. Re-teplase, re means you have to again give. So there is 2 bolus, 30 minutes apart. 10x teplase, it is a big name and it is single bolus. It is a weight-based criteria. Mostly we get patients within the 50 to 70 kg weight range. So it is either a 30 milligram or 35 milligram. And smaller centimeter, so you can reduce it to half. So the dose that you have to remember is this one. It is basically 100 milligram. Among them, you are giving a 15 milligram IV bolus, 50 over 30 over half an hour, and 35 over 1 hour. This is the easier way to remember. 15 is the bolus, 50 over 30 minutes, 35 over 60 minutes, total 100 milligram. Nobody is using streptokinase anymore. Contraindications, just know that intracranial hemorrhage, ischemic stroke in the preceding 6 months, CNS neoplasms, recent major trauma surgery, known bleeding disorder, aortic dissections. These are all absolute contraindications. If the patient is on oral anticoagulant therapy relative, once again a previous EDIC-1 exam question, pregnancy is a relative contraindication, or within 1 week postpartum is a relative contraindication, it's not an absolute contraindication. Because what will happen is that mostly there will be an abortion. The baby will die. The mother will be saved. Okay, so that is a relative contraindication, not an absolute contraindication. Active FTA also infective endocarditis. I think it's a common sense. These are relative contraindications all. These are the ones which are actually asked in an exam. The ICH things, central nervous system thing, gastrointestinal bleeding, aortic dissection is very, 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 very important. Aortic dissection is an absolute contraindication. Recommendations, actually the window period officially is 12 hours, maximum 2 hours, but people are doing it to 24 to 72 hours also. Late presentation you can do, as I told, up to 48 hours it is an you can do. CABG for for ICU people, CABG you just have to inform the cardiothoracic surgeon, nothing else. Ideal timing is after 3 to 7 days once the patient has stabilized. Early CABG there is increased mortality. Immediate CABG only if there is refractory ischemia effects of shock which is not controlled by PCI. It is a very rare thing to do and it is usually not done because it is a surgery. So aspirin, because it is an ACS, can be continued. The second APD needs to be withheld, unlike PCI where you can continue with both. The indication is with failed PCI, amenable to PCI, or not amenable to PCI. Okay. Long-term management will not be asked in EDIC because it's a ICU-based exam. You have to continue dual antiplatelet therapy, the second antiplatelet for 12 months, beta blockers, ACE inhibitors, and aldosterone, or a diuretic, dietod or diuretic, those type of things you have to add. And blood pressure control, smoking cessation, sugar control, and regular follow-up. Reduce the weight. These things are long-term management. These are just recap of what we have already discussed. Complications. In an MCQ, they will ask that the patient is in shock, severe shock, not responding to anything, or they will give an echo finding and you have to find it out. Usually they give you a ventricular septum rupture, acute MR, rupture of the free wall, any cardiogenic shock, arrhythmias. So these are the questions which will be a picture-based question. They will give a ECG finding, echo finding. In fact, they can also give you a, because in UK or in the European countries, in the Asian countries, actually in India, we have almost eradicated the use of the this CVC pressure monitoring. CVC pressure or the pulmonary artery. Sorry, I'm so sorry, not the CVC, obviously, the pulmonary artery catheter. Yeah, pulmonary artery catheter. But there they give the pulmonary artery catheter values. So in pulmonary artery catheter, they have put a pulmonary artery catheter, and they have noticed that there is a widespread pressure change. So what can it be? Then you have to think of a myocardial septal rupture or those type of things. These are all be the practical questions, so nothing theoretical about these type of things. Arrhythmias, reperfusion rhythms can be there, no indicated therapy, and once again the exam will be more clinical based. Increased mortality if it occurs in the first 48 hours. The usual management of arrhythmias will be applied. Correction of potassium, magnesium obviously is very important. I think you all know that those are the ones which will be causing the potassium, magnesium. That is very important. Conduction blocks, we have to diagnose the conduction blocks. There's nothing to discuss today. If in cases of sinus bradycardia or hemodynamic intolerance, then we can use epinephrine or atropine. Temporary pacing is another option. If there is acute heart failure, then we can use the diuresis, nitrates, NIV, or intubate. There can be symptoms of pulmonary congestion. So once again, they can, give a chest X-ray or give the clinical features or edema, those type of things. Or cardiogenic shock. They can give you the picture of a monitor, the cardiac output monitor device, and then you have to discuss because that will show the cardiac index, that will show the pulmonary capillary wedge pressure, that will show the other things, obviously the cardiac output, the heart rate, the blood pressure, the SVR, the PVR. On the basis of these findings, you can decide whether you can use a dobutamine or a noradrenaline. So these are the separate PPTs. Acute heart failure itself is a very important topic for EDIC. So we shall not go into details, but do search for these cardiac monitor photos and try to interpret them and see what they are telling. Life in the fast lane as well as Pulmocrit. All of these are very good sites for critical care medicine. Online sites, absolutely free of cost. You can just go and Google these things, and there you will get very good ideas. 30 minutes in those sites regarding these things is a very clear idea when to use dobutamine, when to use NORAD. If the SVR or PVR are more, SVR is more, go for dobutamine. PVR is more, you can go for dobutamine. You can also go for levosimendan. But levosimendan in an ICU has got a increased mortality. That is a bad effect, increased mortality or more chance of winning failure intubated patients. So nobody uses levosimendan. So if you're working in an ICU, I think most of you you guys are quite senior people, and then these parts will be very easy because these parts will be absolutely clinical based. There will be no theoretical based thing in the EDIC part 1 from these acute heart failure, cardiogenic shock type of things. Once again, IABP, LVADs, ECMO. Yeah, just go through the trials of ECMO, the trials of the IABP, and the graphs of the IABP. Whether there is the early balloon inflation, late balloon inflation, which graph is showing the which thing, and the ECMO, whether the parts of the ECMO went to the VA ECMO, went to the VV ECMO, these sort of things, and basic identification of the machine. So that if they give you a machine, they give you an oxygenator, if they give you the the ECMO lines, so that you can just diagnose that yes, this is an ECMO oxygenator, because this is a MCQ based exam, and you will only be diagnosis is enough. Nothing else will be needed from you. Yeah, so IABP, it prevents hypotensive events, improves coronary flow, increases drug delivery to the thrombus. Aneurysms, it is a very common to misdiagnose aneurysms because it increases mortality 6 folds. Persistent ST elevation more than 4 weeks will definitely be in the MCQ stem. It is a rare thing. Complete occlusion of the artery, and the treatment is you have to go for a PCI. Free wall rupture, mortality, I don't know why mortality is 20% written. Mortality is at least more than 70%. Okay, this is sudden pain, complete collapse, electromechanical dissociation, AV blocks, pericardium tamponade. These will be seen, and the free wall rupture. And in the MCQ also, you will mention it. As I told, there is a new onset loud systolic murmur. The onset is usually from the second day to the seventh day. That is in the first week. Ventricular septal rupture. IABP for bridge to surgery, followed by CABG. Very high mortality. There are percutaneous closure devices. Interventional cardiology is a very upcoming branch, and they are working very nicely. Even in my setup, Apollo Kolkata also. And you're seeing these patients more and more. Device closures in different cases. Very interesting state of the art things. Papillary muscle rupture, how to diagnose. So basic thing is a fever rupture. There will be, the patient will be very ill. There will be hemopericardium or tamponade. In VSD, there will be this murmur, and this timeline will be there. In papillary muscle rupture, there will be a systolic murmur. Echo, there will be an MR, and usually it is difficult to diagnose because you have to find out that there is a papillary muscle, posteromedial papillary muscle rupture is there. And there will be pulmonary edema, shock, which can be present in any of these three cases. So not very useful. But the not very obvious systolic murmur, capillary muscle rupture can be one of the cause. You just have to rule the other things out. That will be enough. Coming to non-STEMI, NSTEMI. In STEMI, we are mostly going for the PCI. Non-STEMI are not. But the thing is changing now. Non-STEMI also people are going for early PCI. And so the treatment is similar. Anti-anginals, dual antiplatelets, anticoagulation, statins, stratification by Grace and TIMI score, and decision of PCI. Stratification how? By Grace score. I think everybody knows what Grace score is, and by the TIMI score. So TIMI, there are two things. One is a post PCI, how good the flow has occurred. That is a TIMI flow, and another TIMI score for restratification for NSTEMI. So early initiation of beta blockers, classify as Kilip class 3, class 4, nitrates, calcium channel blockers can be used, aspirin for all, P2Y12 inhibitor, that is the ticagrelor or prasugrel is recommended for 12 months. So same as STEMI, no change. These are also same. Unfractionated heparin, enoxaparin, bivalirudin. Fondaparinux was an absolute contraindication in an STEMI, as I told. In STEMI, it is not so, but it is very rare that a cardiologist or a person who is working in a cardiac ICU will actually go to fondaparinux. So my recommendation will be, don't go for the fondaparinux even if it is non-STEMI. Just go for the heparin, enoxaparin, and bivalirudin if there is a hits. So this is the Grace score. No need to remember. There's a cutoff is 140. Grace cutoff is 140. TIMI for cutoff is 3. More than 3, you need to do a PCI. This is for non-STEMI. Please switch on the microphone. So age, more than 3 risk factors, use of aspirin, known CAD, angina, AC segment deviations, elevated cardiac marker. These are the 7 points. And these are the very high risk criteria which mandates a invasive strategy. Very straightforward: hemodynamic instability, recurrent chest pain, mechanical complications, recurrent dynamic ACTF changes, acute heart failure, life-threatening arrhythmias, cardiac arrest. As I told, Grace score cutoff is 140. This is once again symptom onset, NSTEMI diagnosis by clinical features, ECGs and the troponin values, PCI center or non-PCI center. If PCI center and if these high risk criteria are present, go for the PCI. If the restratification is intermediate, then wait, go for the medical therapy. If worsens, go for the PCI, and like that. So immediate PCI is not for NSTEMI, it is for STEMI. Yes, so when there is no ongoing symptoms, no acute heart failure, no dynamic ECG changes, ejection fraction at least more than 40%, then this is the only scenario where no PCI recommended, regardless of whether it is a STEMI or a NSTEMI. Because the concept of STEMI and NSTEMI is decreasing. It is the now mostly a obstructive coronary artery, OCA. So the topics are over. These are some of the ECGs. If somebody can just volunteer, if you guys just LAVIC and everything. There are 5 ECGs, not many. So you shall just go reach the diagnosis and move on. Just it like it will be
ST elevation and 2-3 AV. Inferior.
Okay, so ST elevation is in V1, V2, V3, right? And between V4 also. So the walls involved are, and any changes in 2-3 AVF? I think there are changes in 2-3 AVF also, right?
Posterior wall am I? 2-3 AVF
Yeah.
and AVL.
Yeah, exactly. So it is a clear-cut posterior wall AMI. 2-3 AVF is inferior wall, V1, V2, V3, and also some V4. So it's a lateral wall, infralateral wall. So that is basically a posterior wall AMI. Circumflex branch is involved. Okay, the next ECG. Very nice. Whoever told it, very nice diagnosis. That was the most difficult ECG. Others are pretty straightforward. Yeah. So what is this telling? Come on, I think this is too easy. 2-3 AVF there are changes, so it is an inferior wall AMI, and there are the reciprocal changes in V1, V2, V3, because the changes only between V1 and V2. The others are not there. So the lateral wall is not involved in this case, right? Yeah, you see the lateral wall is clearly involved. There are changes in V1, V2, V3, and also V4. Yeah, there are no lateral wall changes, only V1 and mostly V2 and some V1 is there. So mostly 2-3 AVF inferior wall reciprocal changes. Okay, somebody tell what is this telling? Nobody's trying, I think, because if somebody tried, it is very easy. I mean, I've just put it for to make it a bit more interactive, not for any difficult or odd ECGs. There is just some ECG ST changes in lead 1 and reciprocal changes in lead 3 and ST changes in lead 1 and AVL also. So it is a lateral wall AMI. What does this tell? Look at V1 and V2. We've already discussed this ECG today only, or something similar to this.
Valence.
Yeah, it's valence type A because of the biphasic T waves. What is this? I think it's already mentioned what is this, but yeah, if somebody can just elaborate on, I'm sorry, I forgot to crop out that part. Somebody can just elaborate why it is a diagnosis, it will be nice.
ST depression with tall T wave.
Yeah. So yeah, AC depression and tall T waves will be enough, and if they are mentioned deventus in the MCQ option, is the deventus T waves, because there is an AC depression here, tall T waves, AC depression, tall T waves, classically V2, V3, and V4, V5 also. They are a very prominent T waves, almost equivalent to Q-RS complex, right? So this is the deventus T waves. Sorry, I think this is the last slide. Once again, classic STTUF changes seen in the in the leads V1, V2, V3, and V4, V5 also, V6. So basically, these TUF changes are present in almost all the leads. So what is it?
ये depression यहाँ पे elevation है, यहाँ पे भी elevation है. नहीं, ये 2 AVL में ये नहीं है, ये को बताएगा वो. पोस्टीरियर नहीं है, पोस्टीरियर में AVL में, और इसमें दोनों में, इसमें भी तुम्हारे आएगा पोस्टीरियर.
Yeah, so whoever is discussing, it's the STTF changes are there in lead 1, lead 2, and also in the V1, V2, V3, V4, V5, V6 also. So what is it? I mean, so V1, V2, V3, V4, all of these are having STTF depressions, and there is a positive STTF, I mean the positive ST elevation in lead 1, classical for total LMCA occlusion. Okay, multiple V1, V2, V3, V4, V5 ST depressions with 1, 2 ST elevation is classical for total LAD occlusion.
Classical for total LMC occlusion. वो बोला कि टोटली ये टोटल एलएमसी में ये से डिप्रेशन रहेगा और यहाँ पे इनमें एसटी एलिवेशन रहेगा. एंटेरियल इसमें एसटी डिप्रेशन, इसमें ये.
Yeah, somebody is nicely summing it up. If somebody knows Hindi, that's nice. So these were the deventers. I think even if the ECG based questions are a bit difficult, they will not go beyond the deventers, T waves, or these posterior wall AMI, because anterior inferior lateral, so I think everybody will manage. These are a bit tricky. Just practice a bit more, and those timelines, as I just discussed, the timelines are very important. And the gray score and a TIMI score, flows, and they have got those 10 minutes ECG and the 60 minutes PCI, 90 minutes PCI, 120 minutes is a cutoff. Then which drug to use? And yeah, one thing I forgot to tell you, tenecteplase is the most fibrin specific agent. That is the one which is the preferred agent now, but it is not yet in the guidelines. It is still alteplase. It is a single agent, weight based, and it is the most fibrin specific. And streptokinase is the least fibrin specific. And retiplase, that is again, that is one which you need 2 boluses, 10 milligram IV, 30 minutes apart. If somebody is walking in a cardiac ICU, it's very easy. This will be like a cakewalk. But if somebody is not, just go through these things once. From whichever source you are studying, it's too many sources are available. I hope the class was useful today. And if some questions are there, I have not checked the Zoom actually. Yeah, chat, there are a lot of. Okay, you guys are really replying the chat. Yeah. It's difficult to understand which one the answers now, but yeah. Dio enters posterior AMI. Yeah. Nice. I hope you guys, it was useful for you guys. Take care. Good night.